the topic is how and when. So how means the technique, how to go with the technique, and when the technique is useful or can be used to improve our knowledge. How means, first of all, for me in cryobiopsy to have a good control of possible complication. Of the main life-threatening complication we have in cryobiopsy for diffuse lung disease, that is major bleeding. For this reason, we suggest always to intubate the patient. We use rigid tubes instead of orotracheal tubes because we have more space to work. We can introduce more instruments, including Fogarty balloons, radialabus, and so on. But you can do this biopsy also with orotracheal tube. There are some reports, and we have used it in specific cases, the use of laryngeal mask, or even you can have cryobiopsy without any intubation. You insert the Fogarty balloon in one nostril and the bronchoscope in the other one, and in that way you can manage a little bit the possible complication. The second important element how to do this is how to collect good material. So first of all, to be safe for the patient, the second step is, or important step is to collect good material. Probably we have the presentation. Okay. Okay. I promise I will finish in time. Okay. Okay. Okay, thank you. We do in that way, you see. We intubate the patient with a tracheoscope in order to ventilate both lungs without any problem. And because the tracheoscope is larger compared to the bronchoscope, and we insert always the Fogarty balloon inside to hamper, to control bleeding, major bleeding. And the patient is, of course, in general anesthesia, but maintains his or her spontaneous breathing. We don't use muscle relaxant. And here, usually we use the 1.7, but sometimes the 2.4, and in specific contexts, the 1.1. And the guidance is provided by fluoroscopy. You see there, we stay very close to the pleura is another important point to consider. This is our recipe. We freeze with 1.778 seconds, with 2.4, 5, 6 seconds, and we stay very close to the pleura. You can do this with orotracheal tube, or even with the laryngeal mask, or even without any intubation. Why we use large tracheoscope? Because you can use at least 2 Fogarty balloons. If you have biopsy in different lobes, you can use, as in this case, 2 Fogarty balloons. Fogarty balloons is useful not only to hamper major bleeding, but also to decrease the impact of pneumothorax. We don't have hypertensive pneumothorax. So comparisons between different approaches. The diagnostic yield is good, more than 80%, and the mean biopsy area for single samples is relevant for the final diagnostic yield. Strategy biopsy is also important, biopsy in at least 2 different segments if you want to increase the diagnostic yield. and the guiding system. We have fluoroscopy, and it's useful in the large majority of cases. There are data on the use of cone-beam CT, and we published recently this prospective study showing that with cone-beam CT, you can have a very good diagnostic field even in less extended CT diffuse parenchymal lung disease. You see here with cone-beam CT in diffuse lung diseases, you don't need to be so precise regarding atelectasis because we just need to know in which subsegment we are or how far we are from the pleura. Now there is a mobile cone-beam CT you can use more frequently compared to the stationary cone-beam CT. And this was our study. You see here another important element is the last line. Visceral pleura was detected in 41% of the cases. There are some reports, this is our study recently just published 2 days ago, on electromagnetic navigation, in my opinion, is a little less valid compared to cone-beam CT. But you can have cryobiopsy without any guidance. When you are in ICU, and these are reports, case series, or even prospective study, showing that if you have a little bit of experience, you can have cryobiopsy without any guidance. The pathological corner is very important. This is a sample. You see it's 2 centimeters of larger diameter. Very similar, not equal, but similar to surgical lung biopsy, with all the boundaries of the secondary pulmonary lobule, centrilobular area with bronchioles and periphery with visceral pleura. So the dogma that with endoscopic approach you can sample only the centrilobular area is no longer valid with cryobiopsy. And why the pleura is important? These are 2 samples from the same patients with the final diagnosis of NSIP, because we can trust on this pattern if we exclude the involvement or specific involvement of subpleural spaces. You see here we have NSIP even in the subpleural space, so we can be quite sure that UIP pattern is not missed. UIP pattern with high confidence for the pathology, patchy fibrosis, only coming changes, say fibroblastic foci. Here, in one single sample, all the elements showing this histopathological hallmark. The pathological confidence is good, is similar to that assessed in surgical lung biopsy in this study we published some years ago with very good pathologists. And again, why the pleura is important? This is a paper in preparation. We collected different studies, and you see the visceral pleura rate in samples correlates with the diagnostic confidence by pathologists. So don't be so afraid to have pleura in the samples. Safety issue, this is quite peripheral because these are striated muscles, so we are in the chest wall. But it's not so important. Pneumothorax is a complication. I could say a side effect. This is a bad sample because the tail you see here in the sample is a part of the bronchial artery. And so you can have major bleeding for 2 sources, bronchial arteries or veins. So in CT scan, when you have a large vein, pay attention. Why when? Because if you want, I don't suggest it, but if you want to commit suicide, you don't tear the radial artery. You tear the veins because the elastic component in the vessel is not so relevant, and you can have bleeding for a long time. Major bleeding is a life-threatening complication, so for that reason you need some control, and Fogarty balloon is very important. When? So we now know how, or more or less how, when. These are the guidelines we published in 2020 suggesting a bioptic strategy. Probably cryobiopsy first is a valid diagnostic workflow, but we don't have data, or we didn't have data comparing this approach with the surgical biopsy first. We made a study with the Amsterdam or Netherlands group showing that if you adopt this approach, cryobiopsy first and surgical biopsy after, if the cryobiopsy failed, you have less complications and the same diagnostic yield. So when first? When means even if the guidelines say that, for example, in CTD-ALD you don't need histology, this is a debatable, still debatable approach. We made this study with the Vancouver group showing that in a quarter of cases of patients with CTD-ALD diagnosis made by MDD without typical UAP pattern in CT scan, you will find the pathologist, not in our center, but the pathologist that reviewed our samples in other centers identified the UAP pattern. So it means that probably even in CTD-ALD with CT scan aspect suggesting NSAP, you can find UAP in at maximum or in about a quarter of cases. And this as a diagnostic and prognostic and therapeutic relevance. We have some suggestions regarding contraindications. Rapid decline, hypoxemia, pulmonary hypertension, low pulmonary function. And this is a case, 30-year-old male, immigrant from Senegal, smoker, working in a chicken processing factory, almost normal volumes, DLCO less than 20%, and pulmonary hypertension, centrilobular nodules. The diagnosis was not hypersensitivity pneumonitis. The diagnosis was made by transbronchial cryobiopsy without complication, only a mild pneumothorax without need of chest tube, and was unfortunately pulmonary capillary hemangiomatosis. We have some data from the CT scan. We have data suggesting that probably when you have mosaic oligoemia, so scattered cicatricial bronchiolitis, scattered nodules, so low profusion of the disease, cyst, or vascular in three aspects, you should avoid cryobiopsy and proceed directly toward surgical lung biopsy. This is a 29-year-old female smoker sent us with a diagnosis, an hypothesis of lymphangiomatosis. What do you do here? We have a lot of things. I made personally the cryobiopsy, and this is the diagnosis. Langerhans cell histiocytosis, sapets, scars, accumulation of histiocytes marked by CD1A, and you perform molecular biology in the tissue, assessing the MAC kinase mutations. Another case, 80-year-old male with fever, acute respiratory failure nodules. was a very rapidly declining patient. We had the patient 2 hours in our ward. In these 2 hours, we decided to make cryobiopsy. The day after, along with the microbiological investigation suggesting or indicating that the bacteria we found in the intravascular bed are staphylococci, we showed that he had a diffusion, intravascular diffusion of staphylococci. Why biopsy is important? Not for antibiotic treatment, but for ventilation. In this context, mechanical ventilation is not correct because you have barotrauma. And in the last issue of Chest for intensive care, there is a legacy to Professor Gattinoni that passed away some months ago, saying that the most important aspect in ICU is control barotrauma ventilation, not gas exchange. So we sent the patient immediately to ECMO, and he survived. Another case, rapidly progressive patient with ground glass attenuation and nodules. He had a previous hypothesis of lipoidic pneumonia, but the diagnosis was lymphoproliferative process. And in the same general anesthesia approach, he had also an EOS biopsy of the adrenal gland, showing that in the adrenal gland the process was more malignant, and the final diagnosis was leak, lymphomatoid granulomatosis grade 3, that is an EBV-driven lymphoproliferative process. 65-year-old, very young lady, came to our attention for the reason because I'm older, only the reason. The recent discovery of multiple pulmonary micronodules and no clinical or relevant history, normal function test, some nodules, very few nodules, serious in the lung. And the first hypothesis is malignancy, serious in the lung, histiocytosis X if the nodules are in the upper part, or malignancy in the lower part of the lung. Convincity is here. Convincity because in that case the perfusion is very mild, and this was the diagnosis. Nodules, yes, but consisting of meningothelial-like cells, and the final diagnosis was meningothelial-like nodules. That is a very rare entity. Also, the center is important. We need good volume of activity. It means experience. We need the possibility to have access to tools for bleeding control, including, I'm not so sure for that, including interventional radiology and thoracic surgery. And we need experience in ILD. Don't do cryobiopsy without experience in ILD, without experience in ILD. Why? 25-year-old female, congenital sensorineural hearing loss, ICU for acute respiratory failure, renal failure, and hypercalcemia. Some autoimmunity in the background, even MPO ANCA positivity. So you could have a suspicion of vasculitis. You should say, okay, I need rituximab, plasmapheresis, or whatever. These are the CT scan nodules, ground glass opacity. It's not so typical for alveolar hemorrhage. It's quite strange. The age, the CT scan aspect, we have a very good radiologist said, I'm not convinced it is an alveolar hemorrhage or ANCA-related vasculitis. Cryobiopsy, diffuse alveolar damage with deposition of calcium in the hyaline membrane. So we have a disharmonic quantity information, some towards an autoimmunity disease, CT scan, and mainly histology is in another direction. So in that context, because we have experienced, we had this idea, and we showed that this is a very rare entity. Think it is a SAVI, is an interferonopathy. You need genetic test, and you need different approach. If you use steroids or rituximab, it's very dangerous. Absolute contraindication, of course, uncorrectable coagulopathy, and so hemodynamic instability. Common sense, I would say. So I have finished my presentation, just remembering you that we will have the 12th edition of Transbronchial Mediastinal Cryobiopsy in diffuse parenchymal lung disease. And Katarina is present here for the beginning in Ravenna next October. Thank you very much for your attention.
I would like to thank Professor Poletti for sharing with us his experience and expertise. And I would like to ask our commentators, first Dr. Papastαύρου, our thoracic surgeon, whose experience and comments are valuable. We have around 12 minutes, so if you like, we can give some time for questions too. So share with us as the core of your comments. Thank you very much.
Thank you very much. First off, I would like to thank the organizing committee for the invitation. And then I'd like to say that it's been an amazing past 5 years for interventional pulmonology, since new techniques have emerged. Some of them meet us as thoracic surgeons. I'm very happy to be in a hybrid room, that we can have that, but not too many hybrid rooms are here in Greece, so we shouldn't take this always for granted. So we should find new ways that your techniques should meet us. We are very glad to see that pneumothorax and hemorrhages are down compared to CT biopsies. Nevertheless, they're still there. They're still present. Of course, you can manage your pneumothorax just by putting a chest tube in. Nevertheless, you might have to use thoracic surgeon experience once you have a hemorrhage that it's probably too late to discuss about it, and too early for a thoracic surgeon to resolve it. So I feel that it was a great talk by Dr. Titopoulos, that I saw a slide from my friend Calvin Engie, who is right now probably the pioneer and the leader in endobronchial surgery, and his unit in Hong Kong is one of the most amazing units in the world, and it's showing us that we could find new ways as long as you keep pushing from inside and we keep pushing from outside to resolve problems ad hoc. So thank you very much.
Ευχαριστούμε πολύ. Θα ήθελα να ζητήσω και από τον κύριο Σαμψώνα, επίκουρο καθηγητή πνευμονολογίας στο Πανεπιστήμιο Πατρών, το σχόλιο του. Ευχαριστώ.
I would also like to thank the organizing committee for the kind invitation for these comments. I'm very happy that our cryoprobes have evolved from the central airways to the periphery of the lung, and this is important because transbronchial cryobiopsy of any kind preserve the tissue integrity. It is, facilitating and making more easy for the pathologists to establish diagnosis. After the lung cancer screening programs, there is a tsunami of nodules that are coming in to be diagnosed. We need extra technology to rule out that nodes that no need to go for further diagnosis, like AI tools, to discriminate between true negative for cancer nodules versus suspicious nodules, because we may do more harm if we try to biopsy all nodules, and we need to buy a combi CT in every hospital in Greece to do that, and I think there won't be enough space for money to do that, or expertise. B, for lung parenchyma cryobiopsies, I think this is the new gold standard, having in mind the new treatments that are emerging in the medium term for these patients. We are having patients that can take antifibrotics. Other patients need to take, some modification in their immune function with immunosuppression drugs. The drugs are combining both. So in the long term, we need more expertise from the pathologists and from us in order to provide a state-of-the-art diagnosis for our patients in order to take the drug that is going to help them. So thank you so much. Ευχαριστώ πάρα πολύ όλους και όλες εδώ πέρα. Thank you all.
Thank you very much.
So during your speak, Professor, the national TV program came and take some snapshots from Dr. Titopoulos and your perfect things. So the national TV shows tonight these lectures because the new for diagnosis of cancers came up. So we are honored for us.
Now, I would like to ask if anybody, we have about 8 minutes for some questions. So if there are any questions from the audience, please, now it's the time. You have the experts, you have the commentators. Please go ahead and ask anything you like. Thank you.
Thank you so much for both lectures. As a poor ILD physician, I am impressed, of course, that Venerino showed us how much cryobiopsy, also in early ILD, but also in CTD ILD, can provide us a lot of information regarding the histopathological features of the sample. So, I also would like to thank him for the work he did through the ERS assembly, because we both worked for this update of IPF diagnosis to include cryobiopsy in the diagnostic algorithm, but also the role of BAL in combination, with the transbronchial cryobiopsy versus other techniques that are more prevalent in US, Venerino, like genetic testing, etc. So I would like your opinion, because now we are also in front of how we have to predict the disease behavior at earlier phase of the disease. And as Photios, Dr. Shamsona said, it is very important to know from the early beginning of the disease, where we have a very good FVC, maintained DLCO, the prediction with tissue, with the cells, with biomarker. Do we have some insights how to combine also the genetic predisposition of the patients? Because we know very much that now pulmonary fibrosis is not a sporadic disease. We have a familiar background, and we were both in Ancona, where we had a lot of interaction with Mayo Clinic, where they have also put forward the genetic predisposition in the disease and how they take the treatment decision, which is also very important, because we have to avoid immunosuppression, we have to put forward antifibrotics, we have to inform the patients and the relatives. So could we combine this? Can we find a way in our algorithm, to do both together?
Thank you, Katarina. It's a very difficult question. I think everything will pass away. Also, cryobiopsy in the future probably will disappear because of these new, less invasive approaches. So we perform genetic study in our patient in specific context, not in all because of the cost, of course. From the practical point of view, I think that nowadays we need histological identification of the process. If we have the identification of UIP, the prognosis is quite different. We published also a paper recently regarding fibrosing HP, and you can divide into group UAP and non-UAP on the basis of histology and the clinical behavior is completely different. This means that from the practical point of view, we could consider antifibrotic from the beginning, not to wait to see how the disease goes. Of course, I'm almost sure that in the near future, probably even cryobiopsy will disappear. I had a very good mentor, and he told me, remember, if 0.5% of you today say will remain, you are very lucky. So I'm aware of the fact that everything I told today will be useless if I'm lucky in 10 years. So, but today, this is what we can do.
Thank you. I was keeping, to be honest, this question later, but since you started this discussion, I wanted to add to that question, if you don't mind, Professor. We talk about in our algorithms, in our papers, in our talks about multi-diagnosis treatment and MDTs, about interstitial lung diseases. We try to create a culture of lung cancer treatment, again, for interstitial lung diseases. From your experience, is it something practically that it is being done? And maybe is it the solution to our problems on when, as you mentioned to your presentation? Thank you.
The cryobiopsy in our center changed the MDT group. What does it mean? That if you discuss every case with histology, our radiologist, Sarah, is now chair of the classification, so he's acquired a very important role because she, and we have another good radiologist with us, they can improve the lecture, the interpretation of CT scan on the basis of the histology in the background. So it means that cryobiopsy was an important element, just an important feed, an important food for the increase of the knowledge of the MDD. And this was part of our educational activity or our improvement in knowledge. Second point, with cryobiopsy, we learned more and more frequently that if you know at the beginning, not waiting for the progression, what is happening is better. Now we are collecting a group of patients with a diagnosis of UAP longer than 8-10 years that are still almost stable under antifibrotic treatment. Of course, the discussion is you are just collecting patients that are very slow in the progression, but it's not so common in UAP. So I think that one hint is that early diagnosis is better than a late diagnosis. We need, of course, more study on that, more solid study, but this is our impression. And the last point is that we will have very soon a new classification. The biopsy will be part of the new classification. We will have new paper suggesting that probably surgical lung biopsy, even awaked, now we are collecting our experience in awaked VATS, even awaked VATS should be considered the second step, not the first one. It means that if you apply this rule to the general community, you decrease significantly the side effects. So I'm quite confident that for the moment, this job was good, was provided with good fruit. I don't know in the future, and probably in the future we will have less the need of smaller samples. We now have a project on 1.1, so it's an ongoing process, but so far this work we made in more than 10 years changed a lot our approach, and I think also the scientific community approach.
Thank you very much. So we have 1 more minute for a quick question if somebody has. Okay, thank you.
Just a question for both of the speakers. do you routinely, in case of you have a rose positive, so we're talking about cancer, do you routinely perform an EBUS TBNA throughout the procedure, or you just leave it for a second time? Yes. Do you routinely do an EBUS TBNA for suspected or unsuspected end disease? Yes. No, you're done with your cryobiopsy, and your cryobiopsy shows that the rose is an adenocarcinoma, for example. Do you routinely do an EBUS TBNA for lymph nodes? Yeah.
Oh, this is a very good question. In Denmark, in which I stay for a long time, the oncologists require always TBNA, even if the nodule is very peripheral and very small. The guidelines say that is not the most accepted approach because the probability to have metastasis when you have a peripheral nodule of less than 1 centimeter is very low. You don't need to know what is happening in the lymph node. But with the new TNM classification, N1 is becoming a relevant step because with N1 you change. So far, N1 was not important. N2 was important. N1 positive or negative means surgery. But with N1 today, you have to change your approach. Even still, the surgery is in the field, but after different approach. So we have the M1 approach. We don't know exactly when we need to explore N1. How large should be the nodule? How far should be the nodule from the pleura and so on? So it's still debatable. If you want my personal opinion, small nodule in the periphery, I ask for the surgeon to come and to do his job or her job. But this is quite personal. It's not completely in agreement with the guidelines. I don't know I would like to know your opinion. Okay.
So if I may add something to that, though, is that usually when we have a suspected lung lesion, like tumor lesion, we start with staging. But I guess you are talking about the outer third, a small peripheral lesion. Yeah. So please let me take advantage of my role, and I have a question for Dr. Titopoulos. Μας δείξατε τις τεχνικές, πολύ ωραία. Και θαυμάσαμε πραγματικά συγχαρητήρια για την πολύ σύγχρονη μονάδα την οποία έχετε χτίσει. Λαμβάνοντας υπόψη ότι σε ένα σύστημα υγείας μιας χώρας προφανώς δεν είναι αναγκαίο όλες οι μονάδες να είναι έτσι, αλλά και δεν είναι και εύκολο όλο αυτό. Πρακτικά τι συμβουλές θα δίνατε σε έναν άνθρωπο ο οποίος έχει κάποια γνώση, μπορεί να φτάσει στην περιφέρεια, πώς θα μπορούσε μπαίνοντας σε ένα νοσοκομείο που η κουλτούρα είναι επεμβατικού ακτινολόγου, όπως ξέρουμε 9 στα 10 νοσοκομεία, όπως στη χώρα μας ας πούμε, να δημιουργήσει σιγά σιγά μία εμπειρία στο κομμάτι αυτό και να μπορέσει να πείσει τους γύρω του και τους ογκολόγους να τους στέλνουν τα περιστατικά. Ήθελα έτσι λίγο τη ματιά σας πέρα από το πρακτικό του πώς το κάνουμε. Ευχαριστώ.
Έχει αλλάξει η προσέγγιση του οζυδίου σε πολύ μεγάλο βαθμό και συμφωνώ ότι το κόστος είναι πάρα πολύ μεγάλο, αλλά και η εμπειρία και οι γνώσεις είναι πάρα πολλές που χρειάζονται για να το κάνεις, που δεν είναι πολύ εύκολο να υπάρξει μια εύκολη απάντηση. Όμως θέλω να σας πω το εξής, ότι υπάρχει μια τελευταία μελέτη την οποία μπορώ να σας στείλω για το διαγνωστικό αποτέλεσμα της διαθωρακικής βιοψίας στον αξονικό, η οποία αναφέρει ότι αν όλα τα οζύδια μπορούσε να γίνουν με διαθωρακική βιοψία, το ποσοστό θα ήταν 60%. Δεν είναι αυτό το ποσοστό που ακούμε το 90%. Δηλαδή, αν θεωρητικά γινόταν όλα. Τι θέλω να πω με αυτό. Έγιναν οι αξονικοί. Οι αξονικοί μπόρεσαν από τους αξονικούς που έχει η χώρα, πόσοι αξονικοί κάνουν βιοψία, πόσοι δηλαδή ακτινολόγοι είναι επεμβατικοί. Μέχρι να φτάσουμε σε αυτό το σημείο πέρασαν πάρα πολλά χρόνια και βλέπουμε ότι ήταν λιγότεροι επεμβατικοί, γίναν περισσότεροι επεμβατικοί και σιγά σιγά μπήκε στην κουλτούρα του πνευμονολόγου ότι περιφερική βλάβη ίσον διαθωρακική βιοψία. Αυτό χρειάστηκε αρκετά χρόνια. Νομίζω ότι κάτι τέτοιο θα πρέπει να γίνει και στην περίπτωση αυτή. Και σε αυτό την ευθύνη την έχουν τα πανεπιστημιακά νοσοκομεία και οι πνευμονολογικές εταιρείες. Και θέλω για μία ακόμη φορά να πω ότι προς αυτή την κατεύθυνση δεν είμαι και πολύ ευχαριστημένος. Ούτε τα πανεπιστημιακά νοσοκομεία της χώρας που ασχολούνται με την επεμβατική πνευμονολογία, αλλά ούτε και οι εταιρείες έχουν δώσει την δέουσα σοβαρότητα προς αυτή την κατεύθυνση για πάρα πολλούς λόγους και δεν είναι της ώρας να το συζητήσουμε. Και αν αυτοί οι ίδιοι δεν προβάλλουν το κομμάτι αυτό, δεν πρόκειται να περάσει στον μέσο πνευμονολόγο το πώς θα πρέπει να χειριστεί. Και όλα αυτά τα workshop που κάνουμε, και εγώ και πολλοί και εσείς και πολλοί άλλοι συνάδελφοι που αγαπάνε την επεμβατική πνευμονολογία και ασχολούνται για πάρα πολλά χρόνια, κυρίως έχει αυτό το νόημα. Σε ένα βαθμό να υποκαταστήσει το κενό που υπάρχει και σε ένα βαθμό να μπορέσει τον γιατρό, τον πνευμονολόγο, να τον κάνει κοινωνό αυτών των καινούριων εφαρμογών. Δεν θέλω εγώ να κάνω επεμβατικό πνευμονολόγο, το μέσο πνευμονολόγο. Δεν πρόκειται να γίνει. Αλλά πρέπει να μάθει για το καλό του ασθενούς του πώς να χειρίζεται ορισμένα πράγματα. Αυτή είναι η γνώμη μου και σε αυτή την...
Ευχαριστώ πάρα πολύ. Πολύ γρήγορο, Φώτη. Βεβαίως, πολύ γρήγορα γιατί είμαστε εκτός χρόνου. Ευχαριστώ θερμά για την απάντηση στον κύριο Τιτόπουλο.
Να συμπληρώσω κάτι σε αυτό. Η λύση είναι πιο απλή. COM-BIM CT τα επόμενα 5 χρόνια θα έχουν όλα τα πανεπιστημιακά νοσοκομεία. Πριν 3 μήνες έγινε στο δικό μας το νοσοκομείο δεκτή από τους επεμβατικούς ακτινολόγους και τους καρδιολόγους COM-BIM CT αγορά. Το επόμενο που πρέπει να κάνεις είναι να στήσεις ομάδα. Το μεγάλο λοιπόν πρόβλημα στα νοσοκομεία τα πανεπιστημιακά δεν είναι τόσο εξοπλισμός. Είναι ο διοικητικός και οικονομικός συγχρονισμός. Έχοντας στήσει την πρώτη μονάδα επεμβατικής πνευμονολογίας στη Δυτική Ελλάδα πριν 2 χρόνια, το έργο πραγματικά αυτό είναι στα όρια του τοξικού για να γίνει. Οπότε για να προχωρήσει παρακάτω θέλει πολλά πράγματα και όχι μόνο expertise. Το expertise υπάρχει, αλλά πρέπει να υπάρχει και μια, πώς να το πω, πολιτική έτσι βούληση προς αυτή την κατεύθυνση, γιατί θέλει και μια και διοικητική και λοιπή υποστήριξη. Τα ίδια.
Για να μην σας καταναλώσουμε άλλο το διάλειμμα, το break, θα ήθελα να ευχαριστήσω θερμά τους ομιλητές μας, τους παρόντες, τους σχολιαστές και τον συμπροεδρεύοντα κύριο Τρύφων. Καλή συνέχεια και καλή επιτυχία στο συνέδριό μας. Γεια σας.